Hey everybody, welcome to another episode of the HealthTech Pigeon podcast, bringing you the best news stories and analysis every single week. I'm James, and with me today I have colleagues Hugh and Taffy. Taffy making her debut on the HealthTech Pigeon podcast, one of the newest SomX team members. Delighted to have you, Taffy. How are you? Are you scared? Are you nervous about how intellectual this podcast tends to be?
Yes, I feel that I'll be put into the fire today. No, I'm kidding. I'm really excited. I'm really excited to be with you guys and see where this goes.
Why don't you give us what's your background, Taffy?
I have a medical sciences background. That's what I did at university. And once leaving, I knew that I wanted to get into comms, but didn't know where to start. So I worked for a startup as my first job. It was called Stability AI, a great catapult into the whole tech investing kind of world. And then from there, I went on to work in African tech comms, which was really cool because it was close to my heart. It was really amazing just to see the innovation that's happening there. And then from there, bounced into this consumer world, which was really fun. Lots of festival work, influencer stuff. But I knew that I wanted to get back to the heart of health, and this incredible opportunity came at the right time. And wow, I get the privilege to work with the incredible SomX team, on the clients and stuff. So I feel like it's been a bit of a full circle.
Amazing. Thank you. Delighted to have you. And also Hugh's here.
Hi. I'm here to bring the intellectual level of this podcast all the way down.
It's been one of those weeks, hasn't it? Oh my goodness. But we've got lots to talk to you about today, listeners. We have a brand new HealthTech seed fund, thank goodness. We have NICE changing some stuff on HealthTech programs. And we have AI potentially being involved in end-of-life decisions, or should it be? ? You probably know my position on that if you've listened to this podcast before. So let's crack into the stories. Cool. So first story this week. So Nina Capital, they've raised a new 50 million euro fund, and it's set its sights on early stage health techs. And it's reported in Sifted this plans to invest in 25 pre-seed to Series A startups, and they haven't quite landed the whole 50 million fund yet. They've done a first close of 16.66 million, very specific. So they've had that amount committed by their investors, the LPs, which includes 7 partners, some family offices, and some very, very wealthy individuals from the US and Europe. They're going to invest that into some startups. This is awesome, because we've missed out, haven't we? We've missed out on new funds, new startups. It feels like we've just been stuck in this post-COVID bubble dearth of new funds and new companies, and just a bit of, I don't know, a bit of sparkle has gone from the health tech ecosystem when you lose that kind of early stage energy and new people and youth and exuberance. I feel like the space has lost it a bit. So I'm super glad that we are now seeing, 250K to 1.5 million checks into pre-seed and Series A companies. I think it's awesome. And Nina Capital as well, they're going to reserve 60% of that fund for follow-on. So they're going to invest 40% of that 50 million into early stage companies. And they're going to reserve some of that for whichever the winners are into Series A, and put more of the fund into that. What do you think, guys? Excited?
Yeah, I'm not going to lie. I think this is, as you say, it's really good news. I mean, I think the last 18 months or so, we've just been watching bigger investors go after bigger companies and Series A's and Series B's, and people want to put money in things that they've got the track record, they've got the proof of concept, they've gone beyond that, and they're commercial companies, and absolutely that's made sense. That's where the industry is, but I think this is filling that gap in a way that can only be a good thing. I think 2024, I think we saw a lot of great companies struggle in exactly this window. We're here we're almost there. We just need to put some more money behind this to get to where we need to be. But there was no one coming out to put that funding behind and really give them that backing. So this is excellent news. I think if you look at the portfolios of the companies that Nina Capital already has, you can sort of see the breadth they're looking at. I think they're also right in their focus through 3 core areas: companies solving problems across diagnostics, medical devices and clinical training, healthcare infrastructure, and clinical pathways and operational efficiency in hospitals. It's clear where the priorities from health systems are coming in. This aligns pretty much perfectly with that. And I think it's exciting to see. I'm interested from James, you've been in this space before. I'd love to sort of, says here, Nina, as with its previous funds, it looked to take 8 to 10% ownership in the startups it invests in, sometimes a little bit more. What from your experience, what's that? Is that kind of traditional route? Is that kind of traditional amount for?
I think so. It's in and around. I think it's being in this space before. Yeah, I mean in the accelerator world, yeah, famously almost raised the fund, etc. But yeah, in the or infamously almost raised the fund. That's a different story. Yeah, 8-10%. Yeah, it's probably about, yeah. You're looking at that for those sorts of check sizes. But yeah, no, it is. There's a quote in here as well, which I think is really nice. Don't think about the traditional old-fashioned med tech. Think about the next generation of data-driven medical devices that are coming to the market. AI-powered devices which more accurately diagnose and monitor conditions than previous technology could. It's interesting language. It's language that it would make anyone that's regulatory inclined shriek a little bit of like, oh, are you doing all of that stuff? But then again, super interesting recently, Skin Analytics, class 3 autonomous medical device diagnosing skin cancers. Incredible stuff. It is happening. This sort of, don't say diagnose, don't say treat. These are things now. These are things. These are going to get regulated. These medical devices. It's now happened. It feels like Skin Analytics have really broken a duck there, because I haven't seen that before. I actually recorded a podcast with a guy called Josh, and we're actually talking about this. We were like, yeah, we don't think there's any. In fact, we put a clip on LinkedIn, or I put a clip on LinkedIn that was like, yeah, I don't think there's any autonomous medical devices. And Skin Analytics commented on it. They're like, no, this thing has just come out. And then a couple of weeks later, they sort of announced it themselves, which is like it's incredible how fast it's all moving. But yeah, more accurately diagnose, monitor conditions. I mean, this is the new ambition now, and it's turning into reality, and it's a really exciting place to be. And for a fund to come out and lay a marker in the sand of like, hey, we're backing early stage health tech companies. I think this is so great. It'd be so fun to see who they invest in, and I hope they start doing well, and I hope it, renews or lights another fire into this part of the ecosystem, because I really think we've missed it massively.
It's a nice first line in the sand, isn't it? And hopefully the results we see on it replicate the previous ones. I love this stat of more than 80% of pre-seed startups Nina invested in from its first fund went on to raise seed funding, like from round to round. Those are not typical numbers.
No, pre-seed to seed to Series A, that's valley of death, isn't it? Yeah.
I agree. I think it's really great to have this influx of change, hope for the ecosystem, and I can imagine it actually probably inspires, startups to really believe that they can get the funding, because I think that can be sometimes the block for innovation. Sometimes people don't have the supporting funding to drive innovation. I guess to put a spanner in the works, I think the only thing that I have, a query about is, with all the money that's being pumped into it, what are the systems in place to really support the companies to grow? Because yes, we can, have this massive inspo, but how do we prevent a crash? How do we prevent anticlimax?
It's a very wise comment. Taffy, because this is the thing about VC funds, is that it's a competitive process for if you're a really, really, really good startup, it should be competitive to participate in the round. So VCs should be competing with each other of like, please take my money, don't take theirs, please take my money. And they say a good VC does three things: scouting, selecting, and supporting. And that is literally supporting. It's probably far more than a third of what makes a good VC, because ultimately, if those VCs are well connected into customers and partners and Series A and B VCs that can go on and fund you beyond that, these are the things that founders good founders should be looking at, especially the exited founders, second, third companies that can kind of take their pick because they're proven. You're absolutely right. The valley of death exists. It's awful, and part of that can be mitigated by the support of VCs. And it's interesting, when I was raising my fund with Alex, this is one thing that we focused on, which is that when you raise a 50 million fund, the classic sort of business model, it's called like a 2 and 20 model, which basically means that the people that have thrown the 50 million in for you to start investing, they take 80% of the profit of the fund. The 2 and 20 comes from you keep 20% of the profit of the fund as the managers of the fund, and 2% of the fund goes to paying you. So what most people do, the classic VC model is that 2% goes on salaries and office, and some do innovative things. And that's the thing, is that what we said is that take super low salaries, put all of that 2% into support mechanisms, just do programs, do all sorts. And I know there's some VCs that have specific hiring teams that they'll do loads of hiring with that money and support to help all their companies out. And that's their kind of unique selling point. Others it's product, others it's marketing, others it's this. And so it does become a bit competitive, and it should become a bit competitive as where do you take your money from, which VC? Because actually the best ones will genuinely support you to the next phase. And sometimes founders just want to be given the money and just left alone to get on with it. They're not that interested. But if that's what you want and what you're looking for, then yeah, absolutely, those VCs should be they should be helping you in that. I think it can be a bit of a thing though, like saying we're founder first, we're so supportive. It becomes one of those things in that space that everyone says, so it loses a lot of its meaning. And so actually trying to, it's like saying patient-centric in healthcare. It sort of means a similar thing. But it's very interesting. I find the VC business model very, very interesting, because what ends up happening is that, I said 2% goes to salaries and office and stuff. LPs, the people investing in GPs, they start being quite competitive with that, and they start going, well, actually, why should I give you 2%? Actually, I'll give you this amount of money, but you're only allowed a 1% management fee or a 0.5% management fee or all that sort of stuff. So then you have to go to the... So it's a really interesting ecosystem if you read it, and there's a few good books on it for those people that are listening that are interested in it. If you're interested in economics and maths and startups and stuff. But what I would say is that if you're a startup raising money, if you read the book that the venture capitalists read in terms of how to structure their fund, you end up understanding them very, very, very well. And that's that's the major thing that I got from it. There's a book called The Business of Venture Capital by Mahendran something. I can't remember his full name, but yeah, very, very, very good for people listening. If you're a startup founder, I recommend reading The Business of Venture Capital, because you'll go into a funding round knowing pretty much exactly what to say and what to do, because you know the pressures that they've got and what they need to show.
That's really interesting. I love what you shared about this idea of being in a position to pick which one you want to pick, like this competitive thing of which one should I pick. But I just think there isn't really that space for most startups to have the privilege to say, this is the VC I want it back because of the wealth of knowledge they can bring to the table. So I guess maybe the responsibility lies within the VC to just make sure that they're backing a company they can really see through to the end, and for it to not just be about hype, but for it to be really about sustainable change.
And that's the beauty of the business model. They're incentivized to do so. because if they do, everyone makes money, right? So it's in their interests to do it. And thus the, don't want to say the beauty of capitalism, but anyway, should we move on? Second story this week, going to come straight to you, Hugh, on this one. Nice. They've consulted on changes to its HealthTech program. What have they done?
They are consulting. So it's time to get involved for anyone who cares about cost effectiveness, getting digital health and medical technologies approved for use in the NHS. So now's the time to get involved. But essentially, in a nutshell of this is that what NICE are considering is removing the requirement for medical devices to be cost saving to be recommended for use in the NHS. Now, obviously, this is interesting because it's not that cost is going to come out of the equation. It's just we're going to potentially move from a system of cost saving to cost effectiveness. And I think this is what's interesting in this for me is we've always looked at digital transformation of health and pretty much any public service on does it immediately save cost compared to the analog, completely analog process, right? It's how does that, and that raises the question of, okay, well, if it doesn't save cost, but do we see a benefit? Should it be approved? Is that something we care about? I think that what this gets to is the kind of probably takes digital health and medical technology more into how we might approach, approving a therapeutic, a drug. And it aligns that far more closely with is it cost effective? Does it bring patient benefits to the patient? Does it bring benefits to the service? Does that include savings or efficiency? Are there other quality of life and duration? All of these things will matter just as they do in a non-technological intervention. So I think this is great news personally, just because I think it's so much of the challenges that we have with scaling technology and piloting technology in the NHS is it saving us money? And it's, as a North Star metric for digital health, it's been probably the central one for a bit too long, particularly when you're looking at, and I'm very aware that NHS and NICE are separate organisations. Their approaches and different, NICE will have a different approach and a different approval approach than, say, a NHS organisation that's actually procuring a technology or piloting the technology or deciding whether to continue paying for it after piloting as well. But both currently look at cost saving as that North Star metric. As that changes, my hope is that the culture will change as well, and the kind of what we're looking at from when we're actually using and testing technology and deciding whether it gets that second year, whether it gets that 5-year contract rather than its 6 to 12 month pilot, is going to change. I think there's an interesting line from Mark Chapman, who's the director of HealthTech at NICE, which is, we're transforming our HealthTech program to ensure it meets the needs of the NHS both now and in the future, aims to deliver clearer, quicker and more targeted guidance that fits NHS priorities. I think there's a bit of an interesting one here because, yes, all of these things under these requirements, we can be kind of looking more about how digital health and medtech addresses the kind of wider priorities as stated by NHS organisations. But finance is still going to be there. So finance is still going to be an ultimate priority, and I reckon it's going to be quite difficult to shift that away from being a North Star metric, at least for the financial bods who have a say in, do we keep paying for this? Liam Cahill explains, the concept of in-year capital and different forms of spend in the NHS far better than I think we can, but the same challenges will exist. And I think it's great that these reforms are going to come in and have a look at cost effectiveness. I think it's going to be an interesting one as we move forward. Can the wider healthcare system look at technology in this way? Ultimately, though, I think if just looking at the way NICE assesses tech, moving from cost saving to cost effectiveness is going to be really different. There are some other fascinating elements of the approach as well, looking at the kind of the multi-tech analysis versus the single tech analysis, particularly for multi-tech when there are multiple solutions that perform the same, essentially deliver the same outcome, and assessing them together. But I think, moving forward, this is going to be really interesting news, and I think really does change the way that we think about digital health from a first principles point of view.
I hope it does. It's a subtle change, cost saving to cost effective. It's a really subtle change in language, but it means so much because it just opens up benefits and quality to become part of it. Because previously, and again, like the most damning thing I ever heard when, I mean, it was only a few years ago, but one of the most, I would say, successful NHS innovators we've ever had, who has now left that company, isn't doing it anymore, said infamously, for the NHS to buy it doesn't even need to be good, it just needs to be cheap. And I don't know, like that was like, it's really painful for me to say even now, and it's really painful to hear. And I think he was very much at the end of his tether at that point. He'd been doing it for so long, actually quite successfully. Had so many NHS logos on their contract slide and customer slide and stuff. And yeah, it's a company that most people have heard of. But yeah, it was a very damning indictment of the state of the system. And so yeah, I think it is super important that we change this language, because you're quite right. This sort of stuff won't happen overnight, but language can be so powerful. We know this. We know that populations and behavior will be affected just because there is a word for something, even in certain countries, and that you can quantify things in a certain way. And we know, of course, that things have key messages, and when key messages are repeated over and over again, associations are made, and that does change behavior. And we know that of companies and the importance of language. So yes, language can be incredibly important here. So going from cost saving to cost effective, as I say, brings in a necessity to quantify the benefits and make that part of the equation. So rather than just looking at how much money does this save, it's now how much money does this save? Also, what are the benefits of this to patients, to the system, to this, to that, to the other? And that's, hopefully you can bring quality back in, because again, like, it doesn't need to be good, it just needs to be cheap. It needs to be better than what we had before, and less expensive, and these other things, and finding a way to actually quantify that, I think is just incredibly important. And so, yeah.
And the idea that something might be not cheaper than what we had before, but improve patient outcomes, improve clinical outcomes, improve efficiency within a service should not be rocket science.
Right.
But it has to be at the moment. And
yes,
those are the terms we work with, and for good reason. For we are incredibly stretched, but the thought that it might not be the only metric that seems to matter for a lot of the way we look at health tech at the moment would be a relief.
Yeah, I completely agree. And if anything, like you're saying, it might even take an initial investment to sacrifice more money to get things going, to then get the returns later. Like, if we're going to adopt more technology, that means more training, that means more time taken for people to do courses, and it's going to take a lot to begin with, an investment to then see the reduced amounts, in the healthcare services and systems and stuff like that. So yeah, it's worth putting more in now, so that more lives can be saved, and we can then see that financial benefit later. But I guess the question is, are we willing to invest?
It's a really important question to answer. And I think ultimately that's probably one for a central funding piece.
If there was money to pay for it, we might be willing to pay for it. This is not a question we can answer, is it, when there's no resource? But I think, is it? I think people will be paying for it in some way, and I think people are. I think actually where that probably comes out is that you've got the people within the system that are trying to champion this, that are going out of their way with time. They are spending their resource. They are working collectively as an extra FTE just to help with adoption of something, or just to help with scouting something, or horizon scanning, or whatever term, to like finding stuff that could work. trying to adopt stuff that could work, trying to give feedback to companies that have brought something in that could work slightly better. I mean, people are they're not paid to do this, but they will be doing this as part of their job. So I guess that's where that resource is coming from. Again, it's like the NHS is stood up by the goodwill of its staff. It continues in this way, so I think the resource is probably going to come from there. But as I say, to end on a slightly positive note, I think good change in language. I think if we can carry that through and start considering that in terms of NHS business models, something could actually be slightly more expensive, but it could be a hell of a lot more quality. Can we open up that conversation? So our final story today that we're going to talk about, and I'm sort of leaning forward here because this is really in my wheelhouse. This: should AI make a call on end-of-life decisions? So should AI be used in end-of-life medical decisions? That is the question. And so this is in the Harvard Gazette, and it's sort of like a feature. It's quite a big read, this 8-minute read. And there's people quoted in this from the Center for Bioethics at Harvard Medical School. It's written by someone called Alvin Powell, who's a Harvard staff writer. And this is fascinating because it touches on a subject that I actually used to consider when I was a doctor, which is when someone loses consciousness, ethically, should you act on the balance of probability as to whether they would have a life they would want when they woke up? And would you be guided by that on whether you were to treat them or not? And it's a really strange question to grapple with that kind of comes up in this article, because what they ask about is, well, they talk about, end of life decision making, AI, should it be used in, various bits and bobs, and, can we use it to help with decision making and that kind of thing. But what about the patient who is incapacitated with no family, no advance directives, and so the decision falls to the care team? And in that situation, it's that thing about, well, how do you make that decision? And could a large language model with all the information ever make that decision better or worse? And that's an interesting definition, or better or worse would be in this scenario, better or worse than a human. And would you want, actually, no matter what the outcome, would you want a human to make that decision? Or would you say, actually, if you can absolve the human from that decision, that's actually better for humanity? And does AI therefore have a massive role to play there in emancipating humans from that decision making? So they ask another question, are there areas of medicine where people should always be involved? This is a sort of question. I love this for the questions that it's asking, because these are questions that I really want us to find the answers to. Should a baby's first contact with the world always be human hands, or should we focus on quality of care? And they ask the question as well, are these conversations happening? So I love this article because it explores all of this and doesn't tell you how to think either way. It quotes some people that think on various sides of that. But this starts to quantify something that I believe is genuinely important, which is, where do we draw the line between what we want AI to do and what we want humans to do? So where is the line between humans should always do this onwards, and AI should therefore do the rest? I think that's so important, because when we define that, we can then deploy all of the resources that are currently both sides of that line to the side of the line that we all agree. And actually we can do more quicker and we can get to where we're going quicker in a more focused way. Of course, still debating where that line is and the nuance. But I guess where I see advancement is with more focus. And I worry that we're piloting and trialing AI all over the place at places where we're soon going to think it shouldn't actually be used there. So I love this. And this Centre for Bioethics at Harvard Medical School, I'd quite like to go there, quite like to have a chat to people there, because I think what they're doing is incredible. And it sounds incredibly fascinating. And I like
I'm going to start by putting my patriotic hat on and saying we have the Nuffield Council on Bioethics here, James. You don't have to go.
We do. No, we had the report that they wrote. Yeah, wasn't it the report that they wrote that we talked about here a while ago about the sort of mass genetics testing and whether or not that's going to lead to like weird genetic bullying and stuff like that if everyone gets their genomes tested at birth and all that sort of stuff. I think it was them that wrote that report.
It was. Yeah. So, just saying we've got enough bioethicists here is what, we're all good.
Let's get one on the podcast. Let's get one on.
I mean, honestly, it feels to me like we actually do need one to address this in any depth. And obviously we've got 50 minutes. We could speak for 15 years on these topics, really, couldn't we? There's so much here, isn't there, that you almost need an AI to determine what data an AI would need, don't you? Like there's so many nuances. I think this is, for me, and the kind of wider thing, is an unanswerable question. Because what I value, what you value, Taffy, and what a bioethicist might value, or what a working clinician on the baby point, what the mother may value versus what the clinician may value, will be different. We all have slightly different sets of values, and that's what sets us apart, and that's what makes us different. I can't help but think, the use of AI to absolve us on this kind of decision making and absolve the clinician is an interesting one. But will it ever have enough practical data to make a call that absolves anyone? Ultimately, you are feeding it data. You are bringing it information. You are bringing it data points of various kinds, qualitative, quantitative, on which it may make a decision. And the chances are you won't know how it made that decision. You won't know exactly what
Does a single human have enough data to make a good enough decision to stop them feeling crippling doubt?
No. Do you feel, if you ask the AI to make that decision, that you gave it enough information to make that decision? Now, these are the questions that bioethicists will have to wonder about. We could spend 15 years saying, "Oh, does the AI make the decision based on the right things? What if we could have told it more? What if we could have found it more? What if its values-based decision-making capability is weighted more to that 5% chance of survival than the fact it doesn't know whether it wanted to? Have we placed enough? Have we designed in terms of the decision-making framework it uses? What is it basing decision? Is it the fault of and it comes back to the classic one for all of these clinical decision tools. Is it the fault of the person who programmed it? Can we use technology to absolve anyone? Because ultimately, the clinician didn't personally make a decision, but the clinician brought them that information. Could the clinician have found more information that would have weighted that? Could the clinician have deep dive into 25 years ago where they had a conversation and the person said, I actually don't want to be taken off life support, or I actually want this to happen? All of these challenges are far too hard to answer. And I think with the technology that we have at the moment, that there is still a clear responsibility line, whether or not, you cannot, there is no technology other than maybe Skin Analytics Class 3 medical device, so shout out to them, that is completely detached from the person using it or the person who built it.
Yeah, it's assistive, not autonomous.
Yeah. And, we can say, we gave it all of the data and it made this decision. It was still designed to make that decision in that way. Even if it can't clearly explain it, there is a framework in which it is built that meant that it made that decision. So I still, I think we do land on it. Even the most autonomous systems are in some way assistive, are in some way linked to a human design.
Yeah, they're part of they're always going to be part of a pathway. Humans have to turn it on or off at the very least. So yeah, this has always been my point around the AI versus doctor things that irritates me. And okay, you've got some autonomous, perfect, skin analytics autonomous. Yeah, it's not gonna clerk the patient. It's not going to deliver the news. It's not going to like there's loads it doesn't do. It does this bit of it perfectly. Amazing. Let's redesign the system around it to make the patient experience the best it can be now. Why does it have to be this versus a doctor? It's like, no, this plus a doctor equals a much better patient experience because the diagnosis was 100% accurate and the clinician could then deliver the news and focus on that, and we could select for the most empathic clinicians and da-da-da. So doctor plus device was a superb, perfect experience. This on its own, that on its own was slightly less in each. Like can we not, like, what? I hate the doctor versus stuff. I just want to bring Taffy into this actually, because like, I wonder though, like you're sort of representing the youth here, Taffy, as well. Like we're sort of AI migrants, all of us, but there are going to be a generation of AI natives that have grown up with this, that have much more of an inherent trust with a lot of this stuff. And one of the things in here, one of the things it says in the article, someone's quoted saying, I would want people around, even if a robot does the surgery, because the outcome is better. We would want to maintain the human meaning of important life events. And there's a Brian Cox quote of like, that Earth is the only place in the universe with meaning. We're humans, the only thing bringing meaning to the world. So there's something about like humans having meaning, but I just wonder if there's people just coming through or creating meaning, or there's meaning there just because, like, would you want to go into like a humanless hospital to get a procedure and you have it done? And what is that? That feels odd, and you sort of like, why is that odd? It's just it. But however, I wonder if there's a generation coming through that, from this perspective, and you think about AI adoption in healthcare, you think about the people that will be trained to become the clinicians of the future, the patients of the future. If everyone is just a lot more comfortable with this because they've just existed in this world the whole time, do you need human meaning in a hospital, or do you just want the problem solved by a robot and you carry on? Like, I just wonder, like, what's coming with the young'uns? Like, what do they think?
Yeah. This is a great question. And I think I feel very strongly on one side about this, because AI, I think if we're not careful, it can become an excuse to not take personal responsibility. I think in the generation we're living in right now, a lot of people want to just bypass a lot of things that are happening or close their eyes to situations. And it can be so easy to, like you were saying, say, I didn't make this decision, AI told me to do this. But if anything, AI, in my belief, it should be used as a tool to inform our decisions, to take responsibility for what we're going to decide to do. Rather than it being handed off to AI, we need to use it as a more rational tool. And then as humans, we provide that provide that context to making a decision. You know, like I take, for example, if, you know, like you were saying, someone is on the deathbed, or like they're in the coma, in a situation where like they're not able to make a decision, AI can give us the stats on breathing, potentiality of when they're going to die, but we need that human decision to really look at the bigger picture of, this is a mum to this person, and this is the life that they would have lived. This is the person that they could have, this is the person that they were. This is the places that they shopped. This is the lifestyle that they lived. But AI can't really do that. We need people in the room who will bring that emotive, bigger picture view that AI is just limited in doing. And I love what he shared as well about the data that we input into the machine. So of course not, we can't make decisions without humans. We need humans to really bring life to the decisions we're going to make. And we need the accountability if we're going to protect the future as well, right? Like,
yeah. So from your perspective then, like, if you wanted to turn that up to its maximum, then what would you have AI doing versus humans? Would you have humans that are like specialized in this stuff, like creating the most empathic and hand on you, making you feel better. Because the reason I ask the question is like I just wonder, is because of what we see with younger people and the way that they interact with the healthcare system, and especially the ones that are in the socioeconomic classes that can afford wearables and prevention and all this sorts of stuff, healthcare is very transactional. Maybe it's because nothing's really gone wrong for them that they want to feel cared for, all that sort of stuff. But I just see I see two sort of versions of the future. One version where you're diagnosed at home by some imperceptible technology that you've got a big kidney stone, say, and you're told to go to this place at this time, and then you go there and you have some like crazy ultrasound beam or laser beam just shot into you that you hardly feel, and it blasts the kidney stone to pieces, and you excrete it and you go home, and then you're fine. You've never seen a human, and just problem solve back to normal. Or there's the other side of the future where that's full of humans. That's full of humans making you feel better. And I just wonder like what people actually want and what people are likely to want in the future. Maybe that's both. Maybe that's different for different people. Like, I don't know. But these are the sorts of things that I don't think anyone's questioned, I get, or figured out. Maybe we don't need to now because like we're in the early days of this, right? And I think, maybe that's not even a valid question. Maybe that is just stupid. But I don't know. Like, I just have this feeling or hypothesis that actually, for a lot of people, they just want it to be this like transactional, humanless experience rather than one of loads of human empathy. I don't know.
Can I be honest? I personally don't like I personally love having my GP online. I don't like going in person. So I really value the detachment that we can have with AI. I really do because it's efficient, it's quick. I don't have to and I think us as youngins, like microwave generation, we hear about that a lot of the time. But I think where we need to really have that boundary is maybe for more complex situations where, if there are things that have been vetted and proven to work, keep that AI driven, quick, whatever. But when it comes to the more complex situations like deathbed situation, coma, when it gets a little bit more complex, that's when we need to really get that human in the room. Because I know for me, I wouldn't be wanting to have surgery in my bedroom. I want to be in the hospital. I want to see my surgeon. I want to see the contract. I want everything explained to me. But if it's like a common cold, yeah, please give me AI. So I think it's very important to not have a blanket over the situation, but to really be prescribed to certain situations. Yeah, that's my thoughts anyways.
Throughout this conversation, I've been thinking about the word rational. Like, what is rational decision making? Like, if you take away empathy and emotion and value out of the conversation, and you just have a truly rational approach to receiving care, whether that's your common cold, whether that's going in for surgery, whether that's end of life decisions. If you take a truly can you take a truly rational decision on this? Is our definition of, you could say, I want to go in for the evidence-based thing. So if in theory I can go see my virtual GP, who is maybe a robot, and there is an evidence-based framework that makes my virtual GP totally safe from most of the highest levels of regulatory standards. I can go into my cold, sterile environment that is both literally sterile and emotionally sterile because there's no people in it and there's no empathy. Does that make it the right thing? And is that a rational? There is both a rational thing there in the way we describe it, way like humanity would describe it, a rational thing there that is ultimately I can go and have in this future I can go and receive all of this treatment, these procedures, and I will be as safe, I will be as healthy, I will have the same outcomes as if I went to humans for all of that. It's equally rational to want to expect empathy and care and humans in your treatment. That's not an irrational request or requirement. And I bet you there are evidence-based frameworks that tell you that humans and having the empathy.
There are. There's loads of papers. Better history taking, less hospital stay.
I think if you take away the history taking, because one day they'll beat that. Hospital stay outcomes, post surgery improvement and recovery.
Yeah,
there will be tangible links between having that human input, that even the empathy level in your improving outcomes. In mental health, it's very clear link. There is no way that even if you knew that the system could replicate that kind of human element in the digital, there is no way that the tangible knowledge that you were not talking to a human wouldn't impact your mental health outcomes long term in treatment. The isolation, the loneliness of talking to something you knew wasn't human.
And you know what? I think it could be linked to the fact that we're all just such unique humans. Like, it can actually be, it's pretty impossible to have like a model or like a set rules for this A plus B equals C, because we're all so different. And like, one thing that baffles me is how, even learning at university, how medication, I can take paracetamol, Hugh, you can take paracetamol, but it affects us differently, even though we're taking the same exact drug. Why? Because we're genetically so different. And these factors that are out of our controls affect how we react to that drug. So it's the same thing with AI. How we're going to react to the AI will be different because we're all so different.
That's a very good point. How we're going to react to AI. Yeah. God, yeah. And on the paracetamol thing, yeah, it's probably because all the trials were probably done on people that look more like you and I than anyone else as well. So, yes, there's innate bias built in on that as well. And therefore, if that's what you feed the AI, that's probably what the AI is going to learn as well. And yeah, God, it is fascinating stuff. Guys, listen, thank you. It's been a bit of a heavy end, that, but I love talking about this stuff because I think it's really important. I think it's really important we talk about this stuff. And I think if I was to conclude on that, I think the devil's in the detail. I think you're right, Taffy. It's that there's different people that will react in different ways to this. There's different people that will want different things from this, whether they want it at all. And I think that's the thing we've got to bear in mind. And I've got to bear in mind, frankly, because I'm always looking for some sort of general rule or something that will just push us forwards a long way very quickly. But I think with this, the devil really is in the detail. And I know that when I was looking at, I've looked at the empathy stuff a lot, and I've read a lot of the research on it, and it does matter. It matters so much, but does it matter to the point that you absolutely need it in every situation? Well, when you consider the fact that it's better than nothing, probably not. In that case, okay, where is it not happening? Where is it nothing? Is it people on waiting lists? Well, okay. Is it people on waiting lists that have been there for a long time? Is it people that have been on waiting lists for a very long time that have a certain level of risk for something that could get worse very quickly? And when you think in those terms, you're like, well, actually, yeah, I could find a really, really narrow use case for some of this, and we could try it there. And maybe we could deploy AI there, because at least we can know that something really bad was going to happen if we didn't do something. And that's I think the thing with this is that the more we talk about it, the more that we all think about it, the more that we're going to start to become comfortable with it. But my God, it's moving quickly. All this stuff, like I was looking at the operator model by OpenAI that we can start using now in the UK, I think. So we'll be playing with that at some point. But yeah, it's fast moving stuff. But thanks, guys. It's been a pleasure.
I only care as long as it's cost saving.
Nice.
Well, this is a very cost-effective podcast anyway, although it has probably wasted an hour of a lot of people's time. But anyway, this has been the Pigeon Podcast. We'll be back with you next week. If you want to grab the news stories, you can head to healthtechpigeon.com. Taffy, well done on your first episode. This has been wonderful. Your debut, absolutely. And yeah, we'll be back with you next week. Thanks for joining.